So what she's saying is that you explain to the patient the procedure, the complication, and little bit more details about that, and that is an informed consent. So we will see, is that really the right informed consent? So these are your learning objectives for today, and I hope I am able to achieve those. So we have discussed yesterday that there are many ethical issues when you either, especially for research. We talked about voluntary participation. That means patient has autonomy to decide. What we are going to talk today is informed consent. And also the patient doesn't want us to disclose the patient's identity, because it's a very private thing, whatever illness you have. And if you want to participate or don't want to participate, you don't want others to know that I refuse to participate in a study. So anonymity has to be agreed upon between the investigator and the participant. Then is confidentiality. Also, as what she said, the potential for harm. We need to explain to a patient that is there any harms associated with this procedure or with the study. And finally, we'll talk about publication ethics in result communication. So why do we need informed consent? Because generally our patients are not very much aware of medicine. If you are going to do a procedure, are our patients well read about that? No. But in today's world, maybe some of them read on Google and they come back with a very confused mind. It was much easier to inform patients when we didn't have this Google network. It's more difficult to explain now because they have very varied opinions available to them. So the challenge is much more to do informed consent now. The second, the patient has right about themselves. This is what Vinita talked to you yesterday about autonomy. And the consent to treat must be informed, because then only patients, one, comply with the medications. The compliance rate has been shown to be higher if a patient is given information about that drug. If you just say, please go home and take this medicine 3 times a day, there is more likelihood of patients stopping the drug. So if you give good information, your treatment is likely to be more effective. And then, whom does the patient depend on? Patient depends on their physicians to get information, to get correct information. So that is why, both in clinical practice and for research, the onus is on the physician to give proper information and take informed consent. So informed consent, if you see here, refers to a situation in which all potential participants, patient participate or does not participate, doesn't matter. All potential participants receive as well as understand. The most important word in this whole definition is understand. The patient has to understand, and you have to make sure that the patient has understood. Not that I have spoken and I assume that you have understood. So what we were trying yesterday to figure out, have you understood what has been taught yesterday? Similarly, we have to test with the patient that he or she will understand all the information they need. The next important point is decide. The patient has to make a decision. Should I participate in this study, or I do not want to participate in this study? And that will be dependent on his understanding. His understanding will be dependent on the information you have provided. So all these 3 things are linked. So this includes information about the study's benefit, also the risk. Don't just say that everything is hunky-dory. That you participate, you will be great. This drug is 100% efficacious. Most people, what do they say? We will see what are the problems with informed consent. The funding. He has a right to know that is it a drug company sponsored project? Is it an investigator-initiated project? Who is going to pay for it? Or does he has to pay for it? In our institution, lot of study was still done, where the patient pays for it. And has the study undergone an institutional approval or not? So if you see in GCP, because this is the mandate of the NMC that we are supposed to tell you something about GCP and GLP. So this is the definition in good clinical practice. It's basically the same almost. That's a process. It's not a one-time off thing. It's a process by which a subject voluntarily confirms his or her willingness to participate in a particular trial or a study after having been informed of all aspects of the trial that are relevant to the patient making a decision about it, an informed consent document by means of a written signed document. So the GCP says that it has to be a written signed document. While in a lot of our clinical practice, we do an informed consent, like we discussed 3 different types of treatments, but we don't take it in writing in the outpatient clinic that you write it down that you will take this treatment. We take an informed oral consent. But for good clinical practice, it's a written consent. So we always learn from history, as you saw yesterday. So looking at the history of informed consent. So in 1900, Walter Reed took first time written consent for investigating for yellow fever. Rakesh showed you one example yesterday where he took written consent and after saying that we will pay you $100 each in those times. So in 1914, actually is the first time when law came into it. So this is from the US court. When Justice Aggarwal, he first said that every human being who is an adult and has a sound mind. So you see these things. When we take informed consent, it has to be signed by an adult. Person has to be in a sound state of mind. That was described way back. Have a right to determine what should be done with his own body. That determines the autonomy. And then in 1957, Californian government made a law about informed consent standards, which basically means the same things, that you inform everything, benefit, harm, and 1964 is the watershed time, when that Helsinki Declaration came. How many of you are aware of this Helsinki Declaration? Anybody? People keep writing their manuscript that everything was done according to Helsinki Declaration. How many of you have actually read this? None. Am I right? Okay, so nobody is raising the hand, so means nobody has read it. So what the Helsinki Declaration is a long document. So I've just copied the part which is relevant for informed consent. It says that each potential subject must be adequately informed. In this, they added the aim of the study also. So we have to inform about the aim of the study, the methods, the anticipated benefits, and the potential risks. So you see that every time in the history, one of the more items is getting added to it as we are learning over time. Of the study and the discomfort, the subject should be also informed that we have a right to abstain. That is why all our informed consent forms have that you can choose on your volition, own volition, if you want to participate. And if you don't want to participate, that will not affect your standard of care. So that we will not be making any harm to you. And the other thing is that after ensuring that the subject has understood the information, the physician should then obtain the subject's freely given informed consent. Helsinki Declaration says that you can take some consents orally also, like in community studies. It's very difficult to take everybody's consent. So you sometimes take consent only from a community leader. When we do studies in schools, you don't take consent from each child. Only the principal can act as a guardian and give a consent for the whole of the school children. So there it is preferably in writing. And these are the multiple other things which happen. And finally, we have the ICH guidelines. These are basically guidelines which have been harmonized across countries. So these guidelines are applicable all across the world. And as Rakesh told you yesterday, that ICMR has made guidelines which have gradually been revised. 2000 was the first guideline which came, and the last one version is a 2017 version. And what it says is that, again, the same thing, that participation must be voluntary, the participant should know everything. And if you have a child, at least about the age of 6 to 7 years, you can understand. The child should also give assent. This is not a substitute for consent from the parents. You have to have the consent from the parents or the local guardian, but you also can have assent from the child. The child has every right to refuse, even if the parents agree. And that we should actually value. So the aim of our informed consent is basically two, that we want to respect and promote patients' autonomy. And we also want to protect them from potential harm. One, we should not design studies where there is likely to be a lot of potential harm, as we discussed yesterday, about the 3 liver biopsies. So, as somebody said, that a fibroscan may be a good surrogate marker. So, should we really do liver biopsies? So, first we debate among ourselves before we finalize our protocol, and then let the patient also debate and think that is this much of harm, am I ready to take or not? So this is one thing which we need to know, which I think most of us think informed consent is a single event at the start of study. Unfortunately, it's not. It's a process. It should not be taken lightly, and not that we shove a paper in front of the patients and say, sign it here. Neither the patient has right, nor the patient relative has right, and neither you have right. And patient just signs on it. That is not informed consent. So it's an educational process that starts by informing a patient who may or may not be subject of your study finally, who is a potential subject for your study. And it continues throughout the study. If the patient becomes a participant, you continuously give information. If any side effects get reported, you tell the patient that these side effects have been reported in, like when we do multinational studies, lot of side effects get reported. It's our duty to inform the patient. We do it or we don't do it is a different issue. Then it requires disclosure of information, adequate comprehension, and a voluntary decision. So I'm emphasizing the term comprehension and understanding. So if you see here, it's just a line diagram which shows you that you have a good discussion between your potential participants, then see that the patient has truly understood. Patient may accept or reject. If patient accepts, you take a written consent, preferably. You can sometimes take a verbal consent, and we will talk of audio-visual consent also. In certain situations, you have to take audio-visual consent and record it and store it. And then you follow up. If patient rejects, doesn't want to participate, this process ends there itself. So there are two components of informed consent. One, you have to have a patient information document, which will provide all the information to the patient. Second is, there is a consent form. The patient or patient's representative has to sign that form. So what should the patient information document contain? One, you need to upfront say that this study involves research. If it is for a clinical procedure, like when you take patients for surgery, then patient gives a different consent. There you don't need to say that it is for surgery. So what we're talking just now is all for research studies. Then you explain to the person what is the purpose of this study. Then you say how long the patient needs to be in the study. How many times does he have to come? Like we had one study, a multinational study, where a patient was expected to come in 1 year about 30 times. So when I explained to the patient that initially you have to come every week for 8 weeks, and then every 2 weeks for next 2 months, and then every month. He was very right. He says, doctor, our government is giving us only 8 casual leave. So what do you expect me to take? So I don't want to participate. So the conversation ended there itself. So we cannot afford to take 30 days leave for being a participant in that study. So patient has a right to know how many times he has to come and how long he has to come. And description of all what a procedure will be, what are the potential risks, that must be needed. Even if you are taking a blood sample, do you ever write in your consent form? What harm can blood sample do? How many of you have written? You say we will collect 5 ml blood. Has anybody written what side effects can happen with sampling? Anybody? In your consent form, whatever you did for MD or now you're doing for your DM courses, projects, has anybody written? No. And how many of you are collecting blood sample for your studies? Just raise your hands. Are you doing any studies? Nobody is doing any studies. So who is doing studies? Just raise your hands. Let's see. How many of you are collecting blood sample for your studies? 1, 2, 3, 4. Only 10 people are doing studies. Very odd. So isn't all DM, MCA students are supposed to do one study? Are you doing or not doing? Then you're not collecting blood samples. So what are kind of, okay, we'll discuss after that, what studies you are doing. And you also have to write about benefit. A benefit should not be what Rakesh showed you yesterday, $100 compensation. No. So we give compensation sometimes in garb or something else. So you can compensate for their leave. If a person is a daily wage earner, some studies would provide coverage for that. Travel. Patient has to come so many times, you can reimburse the travel. That is not compensation. That is reimbursement. Reimbursement for him taking a leave. Reimbursement for him to travel extra. But you can't give any compensation for patients. And always give, if you are doing a therapeutic trial, what are the alternative therapies available for it. So the patient is informed about that, does he really want to take part in this intervention trial. And then as we discussed earlier, with the confidentiality, it must be explicitly written that all information which is collected from you will be kept confidential. And it should be kept confidential, not that it is just written. And he has a right to know that if he gets any side effects, who will pay for it? Are you going to pay for it? Or he has to pay for it? Because that will make his decision may be different. And finally, as I said, that the patient, it should be explicitly written there that your participation is voluntary. And it will not impact your therapy. And you will not lose anything by not taking part in this study. And also that he can discontinue participation at any time, even after he has given consent. So it does not mean that if he has given a consent, he has become a bonded patient for that study. No. He can withdraw the next day itself. And we should respect that also. And then suppose he dies. Suppose he has an injury secondary to the intervention which we have given. How much compensation will be paid to him? So are you aware anybody has got any compensation for their patients ever? None. So in this institute, the first patient who got compensation actually got, I think, 3 years after his death. His family didn't know. That time there were no laws in India. But when the laws were made, we went back. Because the ethics committee has to act as surrogate guardians for patients. So we said that this gentleman had died at that time. This was some cardiology trial. So we dug out his things, sent to the compensation CDSCO, and he got 64 lakhs. So the son was amazed that we called him to collect that money. But that is what should be available to patients if they participate in some trials. And then You need to have information about whom they can contact if they have any queries. Then your information document also needs to have some additional information in special situations, like if a patient becomes pregnant. Because most of the trials, intervention trial would say that person should not be pregnant, but there can be pregnancies which may not be planned. So what should be done at that time? Then when will this, sometimes what happens is the investigator may terminate a study. A patient is getting a lot of benefit and suddenly you decide the study has been terminated. It could be for many reasons. The sponsor thinks that it's not going to give any benefit. It will never get a regulatory approval. So they don't want to spend money. And they say, okay, we want to terminate the study in the next 3 months. So that patient has to be told in advance that the study may terminate prematurely also. And this we have said that whom to contact, costs we have discussed, and the patient's decision to withdraw. So how should you write a patient information document? Not the way what we see in the ethics committees. It should be targeted for a student of 6th class. A patient information document should be so simple that it can be read by a 6th class student, not by a MCH resident. And that's the quality we see. It should have very brief paragraphs. Because you see any manuscript when we read, even the research papers, if there's a long paragraph, we get bored. We just leave it halfway through. If there are small paragraphs, we think that each paragraph will contain some information, so we like to read those small paragraphs. So that is why it should have small paragraphs. It should have section headers to attract attention. Like somebody is interested in only looking at risks. So it should be written, risks involved. So we can pay more attention to that. Then, as I said, the structure of sentence should be very simple. Not that you have a convoluted sentence which neither you can understand, obviously the patient cannot understand. The size should be good size. Don't try to make it microscopic. Because if you don't want the patient to read, then it is a different issue. But if you want the person to read, at least have 12 font size. Then limit use of complex words. Although if you are going to do some big procedure, like if somebody writes, I want to do basal instrumentation in neurosurgery. They do, is there anybody from neurosurgery? Yes, you have something called basal instrumentation, no? Base of the skull instrumentation, something like that. Then I also don't understand what it is. Leave aside the patient understanding. So write very simple words which somebody can understand. Local language. Translate into local language. Don't thrust upon a language which they don't understand. And always read the patient information document yourself. And it's a good idea to give it to your office staff. That's what I do. I make a PID, I give it to my office staff. I say, you read it. If they can understand, like my PA or the clerk, if they can understand, I think that the patient will understand. So you can run it through a layman. And then that patient information document should be used. So you can read this. This is one of my studies, patient information document, which says that you are being invited to participate in a research study. Your participation is absolutely voluntary. In this study, we are measuring levels of MRP 814, which is not correct. I should not have written that. I should have written that we are measuring some soluble marker in blood in rheumatoid arthritis patients at baseline and after 4 months of treatment with methotrexate. And we want to see whether these levels correlate with methotrexate response or not. So we explain the objective of the study. Then we talk about the drug. We give information about the drug. That methotrexate is the first-line drug for rheumatoid arthritis. That this is the standard of care. So we are not giving you any drug which is not standard of care. Having the best documented efficacy and the least adverse effects. So we are giving you the best possible drug. At present, it is difficult to say that which patient is going to respond to this drug and which patient will not respond. That is why we are interested in doing this study. So the ones who are not likely to respond, we can give them alternative treatment early. Avoiding delays in control of disease. So that is why we are trying to understand, can this thing predict response to method? Then we are trying to explain, if you agree to take part in this study, you will have to give 5 ml of blood at baseline and again at 4 months of starting methotrexate. So 2 times you have to give blood sample, 5 ml each time. And during this 4-month period, you will have to follow up 2 monthly. That means the patient has to come 3 times, 0, 2 and 4. So at 2 monthly to monitor benefit, as well as we will monitor also the side effects, the toxicity, as is done for all patients with RA. So we are saying that we are not doing anything out of the way. It is what is the standard of care, we are only doing that. And for this study, you do not need to bear any extra expenses. So we explain the cost, that the patient is not going to pay any cost. In addition, information of your disease will be collected from you as well as from your file. So we are giving the information to the patient that we will collect some information from his file also. Actually, the patient's files are property of patient. All information of patient actually belongs to patient. When we say that all information will be kept confidential, because we said that its confidentiality has to be maintained. And the study involves minimal risk. So we are identifying the risk. We are saying the study involves minimal risk of hematoma and pain during 2 blood sampling. That when you are going to take blood sample, you may develop a small hematoma there, the blueness, and you may have a little bit of pain. And finally, we say that the study has been approved by the Institutional Ethics Committee. And if you have any questions about this whole process, you can contact these 2 persons. So is there anything lacking in it? Anybody has any comments on it? What you would have liked to change? And this is a study which we did about 15 years ago. What I said is a fault is that we should not use this term like MRP 840. That nobody understands. Pardon? Just speak louder. Smaller paragraphs. Yes, we could have had 1 more paragraph. Anyway, there are only 5 lines. I don't think you can have paragraphs of 2 lines. Blood volume is written 5 ml. Pardon? Can opt out. We have not written that. We should have written that. Great. Anything more? Structure of the PID means? Yes, we could have given headings. Why we did not give headings, we will tell you. Pardon? Anybody else? Do you think patient understand what is a hematoma? It's a scientific word. We should have written that you may have a bruise. Hematoma is not a word which anybody understands. Yes, you could have highlighted, because what we wanted to say at that time was that this is a standard of care which is given to every patient. So we are not doing anything extra. We are only taking a blood sample to say that we are looking at prediction of response. That's why we did not highlight. We could have highlighted, because it's not an intervention study. No, it's not that you're giving 2 groups, anything, nothing. The patient is getting standard of care. So we wanted to emphasize that your therapy is not getting changed. We are only collecting 2 more blood samples to see this. Anything else? Yeah, that's what he said, that we should have written that you can withdraw from the study at any time. And if we wanted to use those samples for later use, we should have written that in this. At that time, we were not writing. Now we write, but it should be written in the PID that whatever leftover samples will be there, we want you also to tell us that would you be willing to leave them for further use. Because we have it in the consent form, but we don't generally write in the PID. Actually, it should be written in the PID also. So now you see Hindi. This is what I did yesterday night. So is it good? Is it bad? And what do you think I have used here? Pardon? So this is Google Translate, which is not good. So we did not use this. I never use this. This is just to show you people. So just read. Can you understand anything? Uttardai Agyar Patrikya Shali Pata nahi kya. Who can understand this? So always make Hindi version in your own language. I could not find the Hindi version of this PID which we had made. We never do by Google. Never. We always write it ourselves in the simple Hindi language. So please don't use. This is slide to show you that please don't use Google Translate ever. If you use it, modify all the complex sentences. Which one? No, that is okay. That is for writing. But you have to translate. Na? You have to make the sentences. Then if you don't know Hindi writing, there is a Google input tools where you can write in English letters and it comes in Hindi. That is okay. But don't translate using Google, please. That is what they face all the time. And this is our consent form. So you need to, if you're going to store the samples, person has to mark yes. Don't mark it yourself. Let the patient mark it. And you see here, the last part. How many of you give consent form and the patient information document, one copy to the patient? 1, 2, 3, 4. Only 10 people. What do the rest do? Yes, the gastrosurgery. What's smiling? Tell us, what do you do? Give a copy. How many of you, what do the rest of the do who didn't raise their hands? So you don't give a copy to the patient? No, why not? Saving trees, that's one option. We are saving trees. Anything else? Any other reason why we do not give a copy to the patient? Then do we have a copy of ourselves also? Of the patient information document, not the consent form. So what I think is that most people don't even have a copy of patient information document. They just shove this and tell the patient you sign here and finished. Nothing is written on top also. So please don't do that. It's not good. Next is who should take consent. Should always consent be taken by physician? So if there is a significant risk or you are doing interventional studies, then the consent has to be taken by a licensed physician. A nurse cannot take consent because you are the best person who can explain the procedure to the patient. Because patient may have many questions on it. If it's a significant risk but non-treatment medical studies, that is non-interventional studies, then consent may be obtained by a non-physician PI or co-PI. If it is minimal risk study like this blood sample, questionnaire based, then it can be taken by any member of the study personnel. But person who is taking consent must be part of the study. It cannot be a nurse who's sitting, who has never, doesn't know anything about the study. She is taking consent. No. So what we need to know about informed consent is that it's not just a paper piece. It's a process. You document the process. Like if you will do good studies, you will realize that we have to write one full page. That what you talk to the patient, what was the question the patient asked, how did you reply? Everything has to be written in black and white and you have to sign on it. And in some studies, even the patient has to sign on it. That the patient agrees that you answered his question or her questions. That is the process that you have documented. I will come to audio-visual consent because this was not happening. That is why we have moved on to the next version. Provide the paper copy to the subject, both of the PID as well as the signed consent form. You discuss the question which the patient has. And it's always a good idea to give the patient information sheet and ask the patient to go home, read it, talk to his family, talk to his general physician, and then make a decision. So it should be an informed decision, not that he has entered your OPD, you are sitting and you say, oh, I have 2 minutes. Can you just sign on this and finish? No, that is not the way to take consent at all, especially for interventional studies. Maybe for blood sample, fine. If he says, okay, I don't mind giving blood sample, it's okay. But for all other studies, and may need to discuss again and again. Like when you do multinational trials, most patients, because the documents are so big, they can't read it in the OPD. They have to take it home and read. Sometimes you need to do reconsenting. You've taken consent once, but what are the situations where we need to take repeat consent? One is when a new information comes and that new information has changed the protocol. Then you have to inform the patient. Like sometimes it might come that you found some people were developing ECG changes and you build in that every 3 months a patient will have to have an ECG. Is that patient willing to get that done? So you have to have reconsenting. Then if a patient, I think somebody will cover, or maybe we are not having anybody unconscious patient. No. So if patient was unconscious and somebody else had given consent for that person, when the patient gains consciousness and is in a sound mind, you have to take reconsent from that individual. Because then the patient is in a state of mind to give the consent. And his or her autonomy, that what we were discussing yesterday about that lady who came to the emergency and she was intubated. But suppose she had regained consciousness and there was some other procedure, obviously we would have taken consent from her. Same thing happens here. When you want to extend the study, you had taken consent only for 2 years. Now the study has got extended to 4 years. The patient has to give reconsent. Does the person want to continue in the extension phase or not? You automatically cannot put the patient on an extension phase. If there is any change in the treatment modality, like you were giving 20 milligram medicine, then you decide you want to give only 15 milligrams, you have to take reconsent. And if there is any chance that you've done the study, and then you realize that you want to put some pictures of the patient, especially where the face will be visible, you need to reconsent. And all reconsenting means that the revision, the written informed consent, so it should be revised, and whatever change in the information is, change of schedule, new test, duration of study, change in the therapy, whatever it is, you write, and then you have to send that to the IRB or your ethics committee. The ethics committee has to be informed. What is the change in the patient information document? What is the change in the protocol? What is the change in the consent form? All has to be highlighted and sent to the ethics committee. Once it is approved by the ethics committee, then only you can use it. And it has to be done within 60 days of approval from the ethics committee. So vulnerable groups, I think we have separate session. So I will leave this here. And children, as I said, I think somebody is going to cover children. So only thing is most important is assent of the child. When can you have waiver of consent? When consent is not needed. Consent is not needed when you are doing research on a publicly available data sets. Like you have genomics data which is available in public domain. You have transcriptomic data. You have many other data. You have, in our country, you have NFHS data, national surveys data. So those you can use without taking any consent. If you are doing review, quality assurance studies, or some archival material, this research on anonymized samples, or you're using leftover samples, but nowadays leftover samples also need consent. DNA, RNA from where it has been stored in biorepository, where you previously have taken consent, then you don't need to take reconsent. And in emergency situation when no surrogate consent is possible, like there has been a tragedy, and then at that time you don't take consent, you just do what you can do for them. But for waiver of consent also, you have to have always send your form to IEC. You have no right to take that I will take waiver. The IEC has to say that you can have waiver of consent. Do not assume it. And then there is some term called review exemption. That means you don't need a review by the ethics committee. But even for that, you have to fill up this form. This is a review exemption form, which basically says that you are looking at audit of educational process. Like we might be seeing that teaching in 100 room people together, or teaching only 20 people in small groups, which gives us a better output. For that, we don't need ethics approval for that kind of a study, but we need to inform the ethics committee. Similarly, for research on microbes, like microbiology does salmonella, they might be looking at antimicrobial sensitivity or some serotypes. For that, you don't need neither the consent nor an ethics committee approval, but just fill up this form and send to the ethics committee. And what is this? This is for waiver of consent. So these forms are available on our website. So whenever you need, you use them. So how can we do better consenting? As I said, use familiar words and ideas, use short words and sentences when you are speaking. Avoid misleading descriptions. I mean, there are things to check, that is your consent form properly written or not. You discuss standard of treatment first with the patient, then discuss the trial treatment. You encourage support from others. Take nurse together with you, because nurse can explain better in their local colloquial language. So have the nurse with you when you are explaining difficult things, and give them information to take home and read and come back and check their understanding. Ask them to repeat that, okay, I told you this, so what did I tell you? That will tell you, did the patient understand or not? And this is what has come for regulatory studies. Drug trials which are going for regulation, they now need audio-visual consent. It was basically because the physicians were not taking a proper consent. So now they want to monitor that, have you answered all their questions or not? Has the patient been given total information or not? How has the process been? So you have to record. You have to set up a system and record. And these are the issues with that, having an infrastructure, you are taking good picture or not, in the OPD is the audio good or not. So these are problems, but we have to do it. If you want to do multinational, interventional trials, you have to have an audio-visual consent. So some institutions have a room, a separate room for audio-visual consent. You take the patient there, you sit down half an hour and take and record. And then that CD has to be kept with you. The problems. Okay, so let me ask you. So what are the problems with informed consent? Let's start from the last gentleman, you. Yes. What do you think are the problems? You face any problems? Yes or no? Yes, so tell us, what are the problems? The next person, if you are still thinking. No problems. So how many of your patients refuse to participate in a study? Suppose you tell 10 people, how many refuse to participate? Or all participate? Most of them? Most of them refuse. So what do you think has happened? If out of 10, 9 refused, means what? What can be the reasons? Why 9 refused? So what the study which you made was not good. But then the study design was faulty. If 9 out of 10 refuse, means there is gross problem with the study design. So you need to go back to the drawing board and redesign your study. Okay. Nikhil, what problem do you face? Time. Residents don't have time to give information. Possible. All of us are even difficult to come here also. Yeah. Patient gets intimidated by any new information. Patient gets intimidated when you tell the patient we are going to try something new. They think it is experimentation. Actually, they are correct. It is experimentation. But it is how we put it. Then Anybody else? Problem of bias.
Then we offer standard of care and then allow us to have a window of art therapy being useful. Like they have a week until the schooling for that in our
So that's what I'm saying, that it has become very difficult to give informed consent in this Google era. Prior to that, it was easier. Anybody else has faced any other problems? Otherwise, we will see the list, what I made. So I feel these are the issues. Investigators do not allot sufficient time. And there are some subset of patients who fail to understand crucial information. Because content of the PID. Randomization is a very alien concept to the patient. And what is randomization? It's so difficult to explain to them. Then they also find it very difficult to understand what is the difference between a clinical trial and a regular therapy. So they think that it is all, whatever is being tried is likely to be more toxic. So they have a pre-formed notion about that. And some patients are the opposite. They will say yes, even if they understand, don't understand, because they want to please their physicians. Because they feel that the doctor will get angry if I say no. Then we are always struggling to balance patient care and research activities. So we don't have time, we are keep thinking. And the other thing is, in multinational trials, because it is an incentive-based trial, it's happening in all 5 continents. As soon as the number of patients will finish, your study will stop. So people want quick entry, and that can affect your consent process. The other thing is, we are only focusing on written documentation. We just want the signature, nothing else, than on ensuring that the patient is understood. We always use complex language. I have shown you my own example. And too much information. Have you seen any drug trial related PID? It's at least 15 pages. Who can read it and understand? And community studies in our country are more difficult. We have some problems which are very specific for India. Lack of education in patients, so they can't read it. Lack of resources. We don't have people who can do one round of explanation. A nurse who can do the first round of explanation, then the physician can do the second round. It helps. And if a patient is educated, patient can read first the patient information document, and then doctor can spend some more time on it. Then it's a male-dominated society. Like in my OPD, every day it happens. You ask the patient, how's your pain? The husband is saying, the pain is this much. So I am amazed. I say, how do you feel pain? Well, with ladies having rheumatoid arthritis, how do you feel pain? But that is how our society is. So most of the decisions are made by males. And fear of the doctor, as I told you. And some of the people get influenced because they will get free therapy. And some physicians also tell patients that you enroll in this study, you will get free treatment, which is actually wrong, which is not right. So, since I finished my time, I'll leave this. This is just giving an example. So there is a checklist also available. This is the last slide for quality assessment. You need to answer these questions. If your PID can answer these questions, that means your patient information document is a good document. So you can just run this checklist after you have made it. And if it contains all this, it's fine. Okay, thank you. Any questions?